The Neurorehabilitation Team. When the brain is injured, whether by stroke, trauma, disease, or degeneration, the journey back is never a straight line. It is not the work of a single doctor, a single treatment, or a single moment. It is the work of an entire community of specialized human beings, each bringing a unique lens, a unique set of tools, and a unique form of compassion to the table. This is the Neurorehabilitation Team, a multidisciplinary and community-driven approach to one of medicine's most complex challenges, restoring life, function, and dignity to those whose nervous systems have been disrupted. At the center of this entire model sits one unifying concept: the Neurorehabilitation Team itself. Every discipline, every specialist, every therapist, every nurse, every family member, and every community organization revolves around this central hub. No single spoke can carry the wheel alone. Together, they form a system of healing that is greater than the sum of its parts. Chapter 1. Medical Specialists, the Clinical Foundation. We begin on the left with the medical specialists. These are the professionals who form the clinical backbone of any neurorehabilitation program. They are the diagnosticians, the interventionists, the ones who first receive the patient and stabilize the ground beneath their feet. Cardiology. First among them is cardiology, represented by the cardiologist and the cardiac surgeon. Why does the heart belong in a brain recovery team? Because the brain and the heart are inseparable partners. Many neurological events, strokes in particular, have cardiovascular origins. An irregular heartbeat, a blocked artery, a compromised circulation system. All of these can rob the brain of oxygen in seconds. The cardiologist monitors the heart's rhythm, manages clotting risks, and ensures that the blood supply sustaining the recovering brain remains consistent and safe. The cardiac surgeon stands ready when intervention is required at the structural level. Without cardiovascular stability, no amount of neurological rehabilitation can take root. Surgery and genetics. Moving downward, we encounter surgery and genetics, a pairing that might seem unusual at first glance, but which speaks to the depth of neurorehabilitation's reach. The orthopedic surgeon addresses the musculoskeletal consequences of neurological damage, the fractures, the contractures, the deformities that arise when muscles lose their neural guidance. The general surgeon manages systemic complications, infections, feeding tubes, emergency interventions. The plastic surgeon reconstructs what injury has disfigured, restoring not only function, but identity and self-image. And the geneticist, perhaps the most forward-looking member of this group, explores the inherited factors that predispose individuals to neurological conditions, helping the team understand not just what happened, but why, and whether prevention is possible for future generations. Specialized care. Then comes specialized care, the neurological core. The neurologist is the primary navigator of the nervous system, diagnosing conditions, interpreting imaging, mapping the extent of damage, and guiding treatment strategy. The neurosurgeon intervenes where the scalpel must go, removing tumors, relieving pressure, repairing vessels. The pediatrician ensures that when the patient is a child, every protocol is adapted to the unique vulnerabilities and extraordinary neuroplasticity of the developing brain. The obstetrician stands beside women whose neurological conditions intersect with pregnancy, a profoundly complex clinical space. And the ophthalmologist addresses vision because so many neurological conditions, from stroke to multiple sclerosis to traumatic brain injury, compromise the eyes and the visual pathways in ways that profoundly affect function and independence. Plus, the medical team. Finally, the broader medical team. The general clinical staff, resident physicians, and coordinating doctors who ensure continuity of care, manage medications, monitor vitals, and serve as the connective tissue between all other specialists. They are the daily guardians of the patient's medical stability. Chapter 2. Therapy and Allied Health, Rebuilding the Self. Now we move to the right side of the diagram, to the therapy and allied health professionals. If the medical specialists are the foundation, these professionals are the architects of recovery. They are the ones who take a stabilized patient and ask the deeper question, what kind of life do we now build together? Physical and functional. The physical and functional team is led by the physiatrist, a specialist in physical medicine and rehabilitation, who serves as the conductor of the entire rehabilitation orchestra. They assess functional capacity, set rehabilitation goals, and coordinate the therapeutic plan. Working alongside them is the physiotherapist, who rebuilds the body's movement through exercise, manual therapy, and neuromuscular re-education, teaching limbs to move again, teaching balance to return, teaching the nervous system new pathways around damaged ones. The occupational therapist focuses on the activities of daily living, the seemingly simple acts of dressing, bathing, cooking, writing, which become monumental achievements in the context of neurological injury. Their work restores not just function, but autonomy. Psychological and behavioral. Perhaps the most invisible, yet most profound dimension of neurorehabilitation is addressed by the psychological and behavioral team. The brain injury does not only affect movement or speech, it reaches into the deepest chambers of identity, emotion, behavior, and cognition. The psychologist conducts assessments, provides therapy for depression and anxiety, which affect the majority of neurorehabilitation patients, addresses cognitive impairments, and supports the patient's psychological adaptation to their new reality. The psychiatrist manages more complex psychiatric conditions, post-traumatic stress, major depression, psychosis that can arise or be exacerbated by neurological damage, often prescribing medications that must be carefully balanced against neurological treatments. The social worker bridges the gap between the clinical world and the real world, securing housing, benefits, family support, and social services. And the vocational counselor, an often overlooked but critical figure, helps patients envision and plan a return to meaningful work, education, and purpose, because identity is inseparable from what we do. Specific therapies. The Specific Therapies group addresses communication and specialized physical needs. The speech pathologist works at the intersection of language, cognition, and swallowing, helping those who have lost the ability to speak, to form words, to understand language, or to safely swallow food and drink. Their work is transformative, as communication is the cornerstone of human connection and self-expression. The recreational therapist harnesses the healing power of leisure, sport, and purposeful activity, designing programs that restore joy, social engagement, and motivation. And the prosthetist designs and fits artificial limbs and orthotic devices, restoring physical capability and mobility to those whose injuries have resulted in amputation or severe physical impairment. Drama and movement. In a beautiful acknowledgement of the full humanity of every patient, the diagram includes drama and movement therapy. The play and drama therapist uses storytelling, role play, and theatrical expression to process trauma, rebuild emotional vocabulary, and restore a sense of agency and narrative in the patient's life. The creative movement therapist uses the body itself, gesture, rhythm, dance, and physical expression as a language of healing, recognizing that the body holds memory, emotion, and identity in ways that words alone cannot always access. Chapter 3. Team Support and Creative Arts, the Human Infrastructure. Below and to the left, we find the team support and creative arts, the human infrastructure that keeps the entire system functioning with warmth, care, and continuity. Nursing. The rehabilitation nurse is, in many ways, the patient's closest daily companion. They administer medications, monitor recovery, manage complications, educate patients and families about care protocols, and provide the consistent, compassionate human presence that sustains patients through the most difficult days. In neurorehabilitation, nurses are not passive caregivers. They are active rehabilitation partners, reinforcing therapy goals around the clock. Paramedical. The paramedical team, paramedics and emergency medical staff, play a crucial role, particularly in the acute phase of neurological emergencies and in the safe transport of patients between facilities. Their rapid response in the earliest moments of a stroke or brain injury can determine the entire trajectory of recovery that follows. Specialized arts. The music therapist represents one of the most scientifically validated and emotionally powerful tools in the neurorehabilitation toolkit. Music uniquely activates multiple brain regions simultaneously, motor, emotional, linguistic, and memory systems, making it a profoundly effective intervention for stroke recovery, Parkinson's disease, traumatic brain injury, and dementia. Through rhythmic auditory stimulation, melodic intonation therapy, and active music making, the music therapist stimulates neuroplasticity in ways that few other interventions can replicate.
Chapter 4: Support and Community, the Ecosystem of Recovery. Finally, and perhaps most powerfully, we arrive at the support and community quadrant, on the lower right. This section carries a message that is both simple and revolutionary: recovery does not end at the hospital door. Family, man, woman, girl, patient, and family. The patient and their family are not peripheral to the rehabilitation process, they are central to it. Family members serve as the patient's primary support system at home, reinforcing therapeutic gains, providing emotional sustenance, assisting with daily care, and advocating for the patient's needs within healthcare systems. Research consistently demonstrates that patients with strong family involvement achieve significantly better rehabilitation outcomes. The family is not just a support structure, they are co-therapists in the truest sense. Globe community. The broader community encompasses peer support networks, neighborhood resources, cultural groups, religious institutions, and social environments that surround the patient upon discharge. Reintegration into community life, returning to familiar places, relationships, and roles, is both the goal and the measure of successful neurorehabilitation. A community that is educated, accessible, and inclusive makes the difference between a patient who thrives and one who withdraws. Handshake organization. Non-governmental organizations, NGOs. Non-governmental organizations complete the circle. These organizations provide funding for rehabilitation services that government systems cannot cover, advocate for disability rights and policy reform, run community-based rehabilitation programs, and connect patients with resources for employment, housing, assistive technology, and social inclusion. In many parts of the world, NGOs are the primary providers of neurorehabilitation services, filling critical gaps in healthcare infrastructure with extraordinary dedication.